Okay, good afternoon, everyone. Thanks for joining us in person and virtually today for the third annual public hearing of the Office of Affordable Healthcare. It's hard to believe time has gone by quickly. I wanted to start with just a couple housekeeping items. The first is that we are recording this meeting and we will post the recording alongside the slides from the meeting on our website by the end of the day tomorrow. To find those, you can go to Our Work in the menu and then select Public Hearing from the menu options. They're all loaded to the recording here as well as the slides. Another small housekeeping item, we're gonna plan not to take questions during the presentation that we're gonna give, just because it's difficult for us to manage in the room and folks online in this webinar style. So if you have clarifying questions about any of the data, we're happy to chat afterwards or to emails or engage on any of those questions. For anything bigger picture, about direction or feedback, welcome hearing about that in public comments. And we'll review this at the end as well, but a reminder, we take public comment today, either in person or virtually, and then we'll also accept written public comment through October 10th, Friday, to give folks time if they want to respond to anything that we cover in the presentation. And just in terms of how public comment will work, Kaylee has a list of folks who have signed up, so she's going to run through that roughly in order of sign up, although we are prioritizing some of the folks who signed up as consumer voices, just so to kind of be respectful of their time, know that they may need to run to other things. So she'll sort of prep that up and she'll let people know who's up next so that you can prepare yourself. If you're in the room, we'll ask you to go to the back corner. It's a little bit of a funny setup, but our usual computer wasn't working today, so we're using the setup that has a camera in the back. So that way you'll be visible to the people testifying and on the recording. So that's the reason for the strange configuration today. So bear with us, please. So with that, moving on to a little bit about the Office of Affordable Healthcare. I'll start with just an introduction of myself. I know everybody in the room at least, but if there's folks online who I don't know, I'm Meg Garrett-Reed. I'm the Executive Director of the office. I'm joined today by Katie Seneschal, who's a Senior Analyst, and Keely Shea, who's a Policy Analyst with the team. This is the full complement to the 3 positions that were authorized for the Office of Affordable Healthcare. It's the first year that we've had full staffing for our annual public hearing. So very excited to be here and to have helped with the presentation. So moving on, the Office of Affordable Healthcare is an independent executive agency that was established by the legislature back in 2021. It's been operating really since 2023 when I had the honor to be confirmed as the first executive director. A little bit about the office's charge. The establishing legislation that created the office directs us to analyze healthcare cost growth and spending trends, including correlation to quality and consumer experience, and also to develop proposals to improve the cost-efficient provision of high-quality healthcare, coordination, efficiency, and quality of the healthcare system, consumer experience, and healthcare affordability and coverage for individuals and small businesses. In addition to those 2 big elements of our charge, we're also tasked with monitoring the adoption of alternative payment models in Maine and around the country. And we also provide staffing support to the Maine Prescription Drug Affordability Board. In addition to the 3 of us who staff the office, we also have a 13-member advisory council on affordable healthcare that provides policy direction to us, and we meet with that group every other month, and it includes several folks in the room today and online as well. So thinking about our charge, I really think about kind of 2 separate categories. There's that analysis and kind of data reporting component, and then policy development. In today's presentation from the office, we're going to run through updates on both of those kind of streams of work that the office is responsible for. It's a big charge. It's one that stepping into this role, can be overwhelming, all those different aspects, being responsible for thinking of ways to improve them. So early on with the advisory council, we developed this set of guiding principles that I just wanted to run through because it does ground all of our work, and you'll hear us reference back to this later in the presentation. The first of those principles is a focus on the big picture. And to us, that means a couple of things. First, prioritizing opportunities with significant opportunity for meaningful long-term impact, really trying to think about the big kind of moonshot type ideas rather than very small little changes around the edges. And also recognizing the complexity of interdependent systems and actors in healthcare. We acknowledge that when you turn one dial in healthcare, it can often move something over on the other side. So this also means that we try to understand the full picture and think about all of those kinds of consequences as we're assessing policy. We also wanted to define affordability from a consumer perspective. That may seem obvious, but when you're thinking about cost control, there can be a difference between sort of what reduces costs for certain actors in the healthcare system versus what is flowing down to actual consumers. And so we really wanted to emphasize consumer cost burden, and especially that burden that results in delayed or deferred care, recognizing that as like a real benchmark for when cost concerns begin to actually impact quality of health. We also really want to avoid policies that only shift cost. We have a small caveat to that, which is sometimes there can be a shift of cost that's done really deliberately to improve health, where a shift of cost early on could maybe save cost in the long run. But by and large, we're really trying to tackle underlying kind of root drivers of increasing costs rather than just moving them from one entity to another, sort of changing the stream of funding. Finally, we really want to deliver results, which again may seem obvious, but it informs the way that we think about proposals and their feasibility. We really want to think about proposals that are achievable and that take into consideration implementation considerations and just the context that we're operating within. That being said, we also recognize that continuing the status quo is not sustainable, that we are on a trajectory that requires significant change that will probably be difficult for a lot of actors across the system. But we need to do that work because we really have a strong mandate to not continue on the path that we're on. So moving on, we wanted to start with an update on our analytics work, digging into spending and utilization. I'm going to start with just a little bit of a grounding in where this falls within the broad analysis planning of the office. So again, because we have a wide mandate, there is no single way that we can take all of these considerations and all of the data sources available to us and put them in one dashboard that answers, all the questions or says, this is the challenge with healthcare spending. This is what we need to do. We really have to think of multi-methods research and kind of combining different analyses and taking away a full picture from that. So over the course of the last couple of years, and especially with Katie's help as she's come on board to work on our data, we've put together this analysis planning framework that also touches on work done by the Maine Health Data Organization and Maine Quality Forum. We already are lucky in the state of Maine that we have an entity that's been working with payment data for a long time and has done some work previously at the direction of the legislature. So while it's their work, not our work, we wanted to account for that and make sure that we're not duplicating that work and we're thinking about how to integrate it in. So that's the center column you see. Over on the left side is claims dashboard work. This is work that we're going to dive into in this presentation to give an update on specifically hospital and facility level payment and utilization data that we've been tracking and are newly presenting on our website. Though we are thinking and working towards expanding that, we have in the works some work to start looking at professional services alongside that and plan in the future when we have a good basis of that data to do some deep dives on cost drivers as well. But that's all working with claims data from the all-payer claims database that's maintained by Maine Health Data Organization. There are lots of analyses that we can't do that. Katie will talk a little bit more about some of the limitations of claims data and information or findings that we can't glean from that. So we've also worked on non-claims analyses in the office, namely some work with the Urban Institute that we did previously to get a hold on what household spending on healthcare looks like in the state of Maine, and I'll share some of that. We have been working with the Advisory Council on beginning to look at both access and equity issues and think about metrics to track those factors over time, as well as think about the data sources that we have available that help give us a sense of provider costs and the impact on affordability there. And then clinical and quality measures are another area that in our statute we're tasked with measuring and that we have on the agenda but have not dug into yet. That's a particularly tricky one. There's a lot of data out there. The quality of the data and reliability is a challenge, but that's something that we'll be looking at in the year ahead. So moving on to talk about some of those analyses and just set the stage a little bit for the conversation about affordability, wanted to return to that work that I referenced with the Urban Institute, where they were able to take some Maine-specific data and use their health insurance policy simulation model to take a look at what they expected healthcare costs to look at in 2025. So this was work they actually did for us last year projecting out, there's no way to actually measure this with a definitive data source because there's not data collected from a lot of large employers, for example. So kind of projections are the best that we can do to get a handle on what this looks like. I think it probably is pretty close to what we've seen this year, though I think there will be changes coming next year that I'll talk more about that may shift what this distribution looks like. But at the high level, I think the big takeaway is that on average, Maine households are spending 10% of household income on healthcare expenses. This is a measure that's not just their premiums. This includes all of their out-of-pocket costs as well, along with other expenses that maybe are outside the paradigm of health insurance. Notably, we wanted to flag that middle income earners spend an average of 13% of their income on healthcare. So that's actually the highest proportion of all income brackets, is households that are between 200 to 400% of the federal poverty level. So I mentioned costs rising in 2026. I'm guessing most folks who are tuned in today or attending in person are probably aware and have heard about approved rate increases going into 2026 and that they are quite high this year. They're 23.9% for the individual market and for the small group market, 17.5%. So you can see, out of step and ahead of what trend has looked like in the last few years in Maine's markets. That's concerning on its own, but notably, there's about 50,000 Maine consumers who are enrolled in health coverage through the health insurance marketplace, which here in Maine is coverme.gov. Those individuals will feel these increases even more because Congress has not extended enhanced premium tax credits that help to subsidize the cost of their premiums. So significant increases there. I think the department has projected more than 100% increases in actual premium costs for households that are middle income earners in the state of Maine. I wanted to just note that we did publish a report earlier this year at the direction of the HCIFS committee of the legislature. That was a report on costs and impacts of state level subsidies alongside other proposed solutions, where we did look at the expiration of those enhanced premium tax credits and did some calculations of sort of what would it look like for the state to replace them. So given that I know, folks are thinking about affordability and what can be done in the face of these increases, just wanted to cite that report, which is on our website. And those expiration of the enhanced premium tax credits do have an impact on those premium increases. When premiums become more expensive, the people who are most likely to drop insurance because of affordability concerns are the healthiest people, the people who are using their health coverage the least. So that can change kind of the risk mix of the market that's covered in the individual and small group market in Maine and make it less healthy. So I know carriers in those filings for 2026 noted higher morbidity is kind of the technical term that they use for that because of the expiration of the enhanced premium tax credits. But taking a look at some work that we did looking at 2025 average rate changes. So these are this year's rates, not next year's rates, because those filings are quite recent. We haven't had a chance to dig in on them. This is some work that Wakely, an actuarial firm, did looking at the rate filings from insurers themselves, just pulling data directly from their unified rate review templates to look at what the components are of an increased premium. And as you can see, medical unit cost and medical utilization are the two factors on the far left of this bar graph. And together they make up by far the most significant component of the premium increases. The other two significant drivers on that left-hand side are pharmacy unit cost and pharmacy utilization. So kind of the combined impact of claims for health services for people. With then about a 1% increase for demographic shifts being noted as well, likely because of our aging population, but other factors may be included as well. So while this isn't reflective of the exact components of 2026 rate changes, we did take a look at the individual filings of carriers and the combined impact of medical and pharmacy, both utilization and prices, remain the biggest driver of those large premium increases that we're seeing going into 2026. So digging into why that is, and sort of some of the factors that are behind those medical and pharmacy trends, wanted to share a graph that we often like to use. This is just from overall health statistics from the Office of the Actuary at CMS. And it shows overall total healthcare expenditures by Maine and the different components. As you can see, hospital services are the largest component of that at just under 40%. Physician and clinical services are just over 20%. That's the second largest component. That does include physician and clinical services in a hospital setting if they're billed as professional claims. And then drugs and other non-durable products are the third largest component, sort of tied with health, residential and personal care expenses. So taking a look at what trend looks like in those categories, we pulled out those three largest categories and showed annual per capita spending over time. You can see here that spending on hospital services has risen up to a little over $4,500 per capita, so per individual in the whole state of Maine. And that ranks us 14th in the nation, above obviously the US average for per capita hospice spending. We'll say this is spending, so this incorporates utilization as well. So certainly thinking about our aging population is a factor here. Understand that over time we're using probably more hospital services because we have a population that's getting older and needing more hospitalization. But still quite a stark, difference in terms of per capita spend between hospitals and then the other two largest components of total health expenditures. And when we think about this from an affordability perspective, I think it's helpful to look at cumulative percent change between these factors. So per capita hospital expenditures are the blue line for Maine, which you can see there at the top. And then annual inflation is the black line, and Maine median household income is the red. So it just gives a sense of how significantly these expenses are outpacing sort of other measures of inflation and of income growth for households, and really explains sort of the changing trajectory of affordability, I think, in healthcare, that these lines are not increasing anywhere close to sort of in tandem, that there's this growing sort of delta between the two. So moving on, I'm going to hand it over to Katie, who's going to do a deep dive on our hospital payment and utilization dashboards. And I'll just briefly say, as I hand it off to her, national health expenditures are a great source in the sense that they are, well respected and well sort of analyzed by folks at the national level. They're, I think, well understood and well established, but we really wanted to dig in a little bit more. It's one thing to say, oh, here's a trajectory of overall hospital spending, but sort of what does that mean? What are nuances in that data? What are different components of that kind of trend that we should understand here at a state level? So that's been part of our goal in the work that we've done with APCD data, to kind of dig in and get deeper and deeper into that data. And that's what Katie is going to walk through.
Absolutely. Thank you, Meg. As Meg said, my name is Katie Seneschal. I'm a senior analyst here at the office. And today I'll be walking through two sets of dashboards that we created in combination or in partnership with the Maine Health Data Organization, or MHDO, looking at data from their all-payer claims database, which is often referred to as an APCD. Where you can find these dashboards, so if you head on to our website at maine.gov/OAHC and click in the drop-down Our Work, you can find these two dashboards. They're open to the public. Feel free to click around. I'll note that in the upper right-hand corner of both dashboards, there's a methodology button. And today I'll do, a brief overview of what goes into these dashboards, but there's a 70-page report on the method. So please feel free to check that out. It should answer most of your questions, but I'm happy to be a resource should any questions come up as well as you're diving into these. So just as a brief overview of the Maine Health Data Organization's all-payer claims database, these data are submitted by health insurance carriers for services that are provided in Maine to people with health insurance. The data represent payments, and so these payments are the combined payment of the health insurance carrier as well as the member liability. So member liability can, broadly be defined as any copays or coinsurance or payments towards a deductible that a member may have. I think an important thing to note that these data do not provide any information of if that member actually did end up paying that amount. That is simply the negotiated setup between the health insurance payer and their member liability, but it doesn't capture if those payments go unpaid. These data cover MaineCare or Maine's Medicaid program, Medicare, and commercially insured members. I will note that the self-insured commercial plans, commonly referred to as ERISA plans, are not obligated to submit to the Maine MHGO APCD, though they do and can on a voluntary basis. And I'll also note that these data do not capture uncompensated care or care for uninsured patients. So those are some of the caveats. I will say it's a very robust data source that we're very excited to use and move forward with, but I think it's important just to note these limitations. So starting off from our dashboards that we presented last year, we thought it'd be a good idea to describe and take note of where we ended last year and how that propelled us into some of the work that we did this year. So these graphs here showing on the left-hand side are inpatient services, total payments for inpatient services, and on the right-hand side are total payments for outpatient services by our three largest payers. So the orange is commercial, the blue is Medicare, and the green is our MaineCare payer. But we can see just quickly looking at the inpatient side on the left, that total payments for inpatient services have remained relatively steady for Medicare in our commercial population and a slight increase in our MaineCare population. But when we look at the outpatient side of things, we see a different story. We see larger increases in total payments for the outpatient services, especially among our commercial and Medicare population, starting from 2020 through 2022. And what we really wanted to understand is, as an office thinking about what trends look like in total payments, we wanted to get a sense of what was driving this type of trend. So we can think about total payments or spending on a really basic level as the combination of how many services are used and the price for that service. So in these data, price, essentially the proxy we use is payments per unit to try to get a price proxy for price, though I just want to note that this is essentially a payment per unit. And then services used, we can look at services per 1,000 insureds in these dashboards to try to get a sense of what is moving these spending metrics at large. So here, taking a look at payments per capita. So payments, total payments among the Maine population in the inpatient and outpatient setting and how that has changed over time. What we saw last year was that from 2017 to 2022, inpatient spending or inpatient payments per capita increased by just under 13% in the inpatient setting and just about under 49% in the outpatient setting. And so thinking about how utilization and price per unit or payment per unit can impact this total spending, we can see that on the inpatient side, we actually have decreasing utilization across this time period by about 13%, but a much larger increase in our growth for price or payment per unit. So here we can see that that 13% is really being driven by an increase in prices in the inpatient setting as opposed to utilization. When we can look at the outpatient setting, we see a similar story. It's not the exact same. We have decreasing utilization that ends in a 5% increase over time, but a much larger increase, I would say, over time in payments per unit or that price proxy. So again, in the outpatient setting, we're seeing this increase in payments per capita really being driven by the price and not so much the utilization of these services. So this is where we ended last year. And we went back to the drawing board and were able to work with the Maine Health Data Organization to get a sense of what we really wanted to know was, do these trends hold at a facility level for hospitals in the state of Maine? We know that our systems are very different. We know that our hospitals are very different across the state. So we wanted to get a sense of what these trends looked like in those settings. So we can dive in, and as Meg noted, we just published these. So I think last week we got these up on the website. So we're still, doing our own due diligence to dive into all the different types of analyses, but happy to show some of the larger takeaways that we were able to look at in the past couple weeks. So here we see total payments and average payments per inpatient day among the 5 different health systems that we have in the state. So the orange line is Maine Health, the green line is Northern Light Health, purple line is Maine General. There's a light blue line that is Covenant Health, so that's St. Joseph and St. Mary Hospital. And there's a dark blue line that is Central Maine Medical Center. In looking at total payments for inpatient services across these health systems, you can see, maybe not surprisingly, that Maine Health and Northern Light Health have the highest total payments. This makes sense to us. They're our largest systems. They also provide, the highest acuity care services. And so it makes sense, really, that they would be receiving the highest total payments for inpatient services over time. We can see, looking at total payments still, that there's Maine Health increased total payments over time, but all the other health systems reported mild decreases or, relatively flat total payments for inpatient services. However, when we look over on the average payments per inpatient day, that's our price proxy, we can see that for inpatient services, we again see Maine Health and Northern Light Health floating to the top. Again, that's not surprising if they're providing, the highest acuity care. But we also see an increasing trend in price across all of our health systems. I will say notably, Maine General and Central Maine Medical Center have a slight decrease in their payments per unit or price from 21 to 23, but all other systems have a pretty significant increase from 21 to 2023 in that price metric there. We can do a similar analysis looking at the outpatient setting. So here in the outpatient services for total payments, again, we see, probably not surprisingly, Maine Health and Northern Light Health rising to the top for total payments with pretty notable increases from 2020 to 2023. We see that Maine General Health follows them, and then Central Maine and Covenant Health almost have, very similar total payments over this period of time, slight increases. But on the right-hand side, looking at average payments per service, or that price proxy, we can see that Maine Health and Northern Light Health have the highest, and since 2020, real increasing trend here, as well as Central Maine Medical Center has an increasing trend from 2020 to 2023, and our other two health systems kind of a little bit more steady over this period of time. And so looking at these health systems, it's helpful to understand, what is system by system, what's happening in the state. But we also know that our systems are comprised of a variety of hospitals, small, rural, critical access hospitals to our largest hospitals in the state. So we wanted to go a step further. And in these new dashboards, we're actually able to look facility, and here we're talking about hospital to hospital. What do these types of trends look like in the commercial market? So this graph looks like a spider, I do admit, but each line here represents a different hospital in the state, looking at the change in their inpatient price per unit from 2017 to 2023. The red line is an average across all the hospitals. What you can see here is that from 2017 to 2023, on average, inpatients payments per unit, or inpatient payments per inpatient day increased just under 30%. At the same time, general U.S. inflation increased about 24%. I will also note that the average payment per inpatient day varies significantly, from a decrease at Waldo County Hospital of 35% to an increase of 139% at Maine Coast Hospital. And so considering how the inpatient price per unit has changed over time, it's also important to note what utilization looks like over this time. So here, this shows inpatient utilization at all of Maine's hospitals, and you can see on average, inpatient utilization has decreased by 25%. But again, this is a pretty big range from, just under a decrease of 7% at Eastern Maine Med to a decrease of 89% at Holton Regional. But on, I would say, pretty significant trend here that inpatient utilization across these hospitals is decreasing for, I would say, almost every hospital, though we have, a couple outliers here and there. And so I think the takeaway looking at our inpatient side of things is understanding inpatient spending is really being driven less by utilization across these hospitals here and more so by changes in that per unit price of services. Now, I'll note this data does not adjust for how services change over time or how the complexity of services may change over time. We do have the opportunity to look at that later in our dashboards, and I'll get to that, but just want to note that here that some of complexity is definitely playing a role in some things like price over time. Next, we can look at the exact same things in the outpatient setting. So here we can see, again, each line is a hospital in Maine. And from 2017 to 2023, we can see there's on average a 40% increase in payments per service in the outpatient setting. So again, that's our price proxy. Again, there is wide variation here where we can see the average payments vary, or average increase in outpatient price or payments per service increase from 100% at Maine Medical Center all the way down to an 8% decrease at Fulton Regional Hospital. So wide variation what hospitals are doing, but I would say the majority of hospitals are seeing an increase in a price per unit over this time. At the same time, we can look at utilization. Here we see the majority of hospitals are having decrease in utilization, but there are a handful of hospitals that have an increase in outpatient utilization for sure. And on average, we have 21% decrease in outpatient utilization across our hospitals in Maine. But again, there's a pretty big range with a 40% increase at Bridgeton Hospital all the way down to an 83% decrease at Penn Bay. And so thinking about in our outpatient setting, again, we have a similar conclusion that, the outpatient price or the outpatient payment per unit is driving spending in this setting as opposed to an increase in utilization during this time. Now, as I mentioned earlier, this doesn't take into account some things like complexity and how that may change over time, especially at certain hospitals that see higher acuity patients, which is really important. So what we wanted to do next was take a moment to dive into trying to control for complexity by looking at a service by service comparison across a subset of hospitals in the not in the United States, in Maine. So here we'll take a second just for 2023 and look at a handful of services that are provided across our peer group B hospitals. And peer group B peer groups are categorized by the Maine Hospital Association as groupings of similar hospitals. This is our second tier below our peer group A hospitals. They span a variety of health systems. There's an independent hospital in here, but they all, generally are comparable hospitals when it comes to the size of the population they serve or utilization, as well as the services they provide. So to better understand how prices vary across these hospitals, we looked at 5 services. So first, looking at something like an emergency department visit for low complexity. We can see here that at Penn Bay, the average payment per unit, so the price for that service, is about $400. However, depending on where you go, that price for that service changes significantly. So it more than doubles at Mercy Hospital, where that is about over $1,000 for the same service. We could look at another service, like a CT scan of the chest with contrast. And you might think that seems awfully specific, but this is how things are billed at that code level to get us to get a better sense of complexity comparisons. And so here, I'd like to note 2 things. First, we still see a pretty significant price variation for services. St. Mary Hospital coming in around $500 for this service, and more than 3 times that at a hospital like Penn Bay. The other thing I'd like to note is that, as you may remember from the previous slide, Penn Bay had the lowest price at a different service. And so thinking about, it's not as simple as saying that prices are always high or always low at certain hospitals. Price variation for services does vary within the service and across hospitals. Next, we could look at a service that has a higher, I would say, average payment. So here, St. Joseph Hospital at just over $3,500 for this service, and all the way down to, more than a fifth of that price at Midcoast Hospital. Don't quote me on that division.
EKGs, ECG.
So the next is physical therapy evaluation. So this is a lower cost service here. We can see that our lowest Midcoast again is coming in as a lower reporting average payment per unit for this service, and Southern Maine almost more than 4 times that amount for the same service. And then finally, for a routine ECG or tracing of heart rhythms, a very common service provided in hospitals, you can see here that York Hospital has the lowest price and then more than double that at Penn Bay. So again, our opportunity here, was really to look at how prices vary for the same services across hospitals that are peers to one another. and also to be able to look at how that varies within a hospital. So there's not one hospital that always has the highest price and not one hospital that always has the lowest price. And so thinking about what that means for consumers, what that means for policymakers, and how we consider price variation in the state.
I'm just going to jump in to re-emphasize something Katie said at the beginning, but I think it's helpful to remember when we're looking at this graph, that when we say price, we're sort of using that as an interchangeable, more accessible term for payments per unit in the data, because that's a little bit of a technical one, but payments per unit using the APCD data are really an average across carriers. So just when we're thinking about this, important to note that this doesn't necessarily have a relationship to, the charge for an individual patient and their insurance plan. It's looking at sort of what is the sum total of the commercial insurance data that we have available from the APCD, and looking at an average across that.
Thank you for that clarification. And then finally, in our new dashboards and where we hope to go in some of our future analyses would be to look at certain categories of services that are associated with higher spending, to be able to track what are really cost drivers in the commercial market for healthcare spending. And so here we're able to look at inpatient service categories with high commercial payments for 2023. We can see circulatory system, so issues of the heart, pregnancy, childbirth, and the time after childbirth, as well as digestive system is coming up as some of our larger inpatient codes that lead to higher spending. And you can see, and this is where we're excited to move next, is how payments per unit, or that, as Meg was just saying, our price proxy here changes throughout these categories. I'll note that there's over 16,000 inpatient days that contribute to these data, but that on average, our inpatient costs are much higher than our outpatient costs. So when we look at our outpatient service categories, we can see that there's 1.3 million outpatient services that contribute to this analysis here. In total spending, some of our high categories in the outpatient setting are outpatient surgery, radiology, and administered drugs. Probably not surprising to anyone here, but also looking over at how our outpatient payments per service varies significantly here. So lab and pathology, as you'll note, looks like it has a pretty low payment per unit, and that's because we can, I'll probably assume that's a probably high utilized service, get labs all the time. And so as we move forward, thinking about where we want to go next, we're excited to, the cost driver deep dives is look at these data and see how those payments per unit and utilization change over time to get a sense of how costs have been driven up over recent years and in what service categories are those being driven by. And then our next area of analysis that we are currently working with the Maine Health Data Organization is in the professional services, so services outside the hospital, because we recognize that hospitals are not the only place that healthcare spending or healthcare exists. And so we're very excited to dive into our professional services, our non-hospital related services, and see how trends like payments, utilization, and payments per unit change over time in those settings as well.
Great. Thank you, Katie.
Yes, of course.
So in addition to the work that Katie has led digging into this really complex claims data, we also wanted to kind of balance that sort of very wonky analysis with hearing from Maine people and trying to get a sense of kind of what's happening on the ground and what are people's priorities as well. So a brief update on that, there was a survey conducted by United States of Care here in Maine back in the fall of 2024, about a year ago. Wanted to share a few results of that I think are helpful in understanding just the general public's perceptions and feelings about healthcare. The first, which I think won't be news again to most people working in this space, is that a little more than half of Maine voters or Maine people find it difficult to afford healthcare, with about 17% finding it very difficult to afford healthcare. In thinking about those concerns and what is causing that anxiety and worry, I thought it was interesting to note that while concern about health insurance premiums and the cost of those is a little over 50%. It's really the universe of kind of out-of-pocket payments and services not covered by insurance that are the big drivers of anxiety and concern about costs for Maine people, with that going up to nearly 70% concerned about medical expenses or prescriptions not covered by insurance. And then the combination of co-payments, co-insurance, and deductibles being of major concern. I think that feels right for any of us who hear from people. Premiums are obviously a concern. It'll be interesting to see if this shifts, next year when there may be more people exposed to higher premiums due to the end of those enhanced premium tax credits. But I think having worked in this space for a while, increasingly, I hear more and more from people who are worrying about those payments at the point of service, even more maybe than premium costs. Most Mainers or many Mainers believe that healthcare costs in the state are higher than they need to be. 46%, saying that they really feel that costs are much higher than they need to be. I think there's, a real challenge of folks not understanding where is all of this money that I'm spending going, especially again when they're paying premiums and then being hit with a lot of out-of-pocket costs when they need to use care. And as I said earlier, we've become particularly concerned about all of these worries and barriers when people report that it's influencing their ability to actually use care. So these are answers that people gave about actions that they'd taken due to medical costs. And a few that I would highlight are 48% of Mainers experiencing discomfort or pain for longer than needed. 50% finding it hard to save for emergencies or other important life events. And then the whole category towards the end, 32% delaying or skipping recommended procedures, 38% delaying or skipping a medical test that was recommended to them, 40% finding ways to try to self-medicate or find treatment alternatives. And then finally, 43% of people who reported that they delayed or skipped going to the doctor when they were sick. And we talk a lot about it can be difficult to trace the evidence, but overall, costs can actually become higher when people are concerned about cost. And so they maybe put off the doctor's appointment or put off the intervention and end up landing in an emergency room, for example, when things become untenable for them. So in addition to just kind of the unnecessary suffering, there's also the concern there about added costs in the long run, both for the individual and systemically as well. In addition to looking at the polling data, whenever we have it available to us, we did also in the office want to think about some other ways to just engage with people on this topic. Really appreciate these annual public hearings, and we get to hear from consumers often, but we know it's a high bar to ask people to take a chunk of time off work and prepare formal remarks and come and deliver them. So we wanted to find a different way that would feel a little bit more accessible to kind of get out into the community and talk with people. So we were able to get some outside funding support to help us host some gatherings. We did one in Lewiston, Auburn, and one in Washington County that were focused on just consumers and sort of regular people. And then we also did a Portland roundtable that was focused on business owners from around the state. And we were able to bring in a simple dinner. We did the Lewiston, Auburn, and Washington County ones at the community colleges there, did them in the evening when folks were off work, and had a facilitator come in. And we just had a conversation that was guided, but rather than sort of putting people on the spot and asking them to report, we just talked with them about their feelings and concerns. So wanted to share a few highlights from each of those meetings. The first up in Washington County, definitely for both this and the next, to no surprise at all, affordability was a big challenge and the first thing that people talked about. They focus a lot on insurance, which isn't surprising at all either, premiums, deductibles, and also flagging the cost of prescription drugs. While insurance carriers and pharmaceutical companies were highlighted, there was kind of concern voiced around actors across the whole healthcare system, particularly a lot of discussion there about difficulty accessing care, long waits for appointments, long waits in the emergency room, and some frustration around kind of communication and care experiences in particular. In that group, a lot of discussion about stigma around either substance use disorder or maybe perceived use of substances and challenges that they'd had interacting with the healthcare system because of that. In Lewiston and Auburn, similarly, the top line was affordability and frustration with insurance costs. In that conversation, there were a handful of people who shared specific stories about when they had delayed accessing care because of concern about cost to them. Again, lots of conversation about long waits for care. In this case, I'm a little more focused on specialty care as opposed to the primary care and hospital care, which is an interesting difference in a little bit more of a populated, I think, part of the state as opposed to a little bit more rural and remote up in Washington County. There was a lot of discussion about healthcare disparities, talking about socioeconomic status, education, geography, and race and ethnicity, as well as kind of drivers in differences in access and quality of care. And then participants there also really highlighted the need for more mental health services. That was an area where there was a strong feeling that generally access was challenging, and especially kind of culturally competent access or access that's trauma informed, kind of truly meeting the needs of people in the community. Then our final meeting with a group of employers, a little bit of a different conversation there. It was a mix of employers. Some are super small and buy through the marketplace or through just the shop options. Some are using broker and are fully insured but larger, and then several are self-insured employers as well, meaning that they sort of don't pay a premium to an insurance company. They just pay the claims and they use a third-party administrator to handle the administration of the plan. So it was a range of different perspectives across the board. Again, no surprise, a lot of struggles and concern about rising healthcare costs and the financial burden that places on them as employers around especially sort of increasing provider prices, driving up their costs. They noted the role that health systems play in shaping cost of care, but access as well. You know, some of the challenges around trying to incentivize different points of access when an individual might be getting a referral from their provider to one specific sort of system affiliated practice. So that was a note. They also cited challenges with access to primary care being a difficulty, and that they had members or employees that had a hard time finding primary care. And then there was some discussion about kind of the way that rising healthcare costs consume resources that would otherwise be used for either hiring, expanding their businesses, or increasing wages. Where folks, specifically noted that they would like to open another location if they could, for example, but that healthcare costs were a factor in being unable to do that. So moving on from all that data and some of the listening that we've done, I want to talk a little bit about policy priorities, but I'm actually going to pause. This is the last section of our presentation, so we'll stop talking and let others speak. I'm wondering, Kelly, if you just want to give the names of the first couple of people who are going to be up to comment, just so that they can be prepared.
Yep, so we have a few consumers online. I think first we have Kelly Martin, then Courtney Shank, and then Patty Kidder. So if you all are ready after Meg finishes this bit, that would be great.
Perfect. Yeah, I just wanted to give some warning. I know, especially when you're remote, sometimes it takes a minute to get yourself ready. So we'll turn it over in a few minutes, but I'll just finish out with the last part of the presentation. So taking all that learning and thinking about how it informs policy priorities. This is something that the office has really started to get involved in or do more work on over the last year. I think when we came in, we really wanted to start by saying, let's create a foundation. Some of those guiding principles focus on the data, but we want to take that now and work towards more action based on that. So we went through a process from late summer through the fall and into the beginning of winter with the advisory council last year to work towards how do we take the whole huge universe of what can be done in health policy and identify some priorities. So our first step was that we identified these broad domains of policy intervention to kind of assess and discuss. There's a lot out there, but we felt like these were good buckets that capture most of the ideas. A lot of them are very interrelated and hard to completely divide out. So that's why you see some overlap in the circles here, but they were subsidizing consumer costs, regulating provider prices, aligning incentives for efficiency, insurance market oversight, provider market oversight, and then finally prescription drug affordability. And the reason prescription drug affordability is a little off to the side there is from a policy perspective, I do think that exists a little bit like within its own construct. The actors that are involved in the sort of structures for how prescription drugs are paid for are a little different. So interrelated, but not quite as much overlap as we saw between some of the other domains that we wanted to note. In thinking about how we could narrow in from those domains, we created a framework for assessing them that focused on 3 major factors. The first was alignment, so thinking about how well the domain aligned with the office's statute and also those guiding principles that I talked about earlier in the presentation. Second was feasibility. Really wanted to particularly call out sort of how realistic the policy would be within operational, legal, and contextual realities. And then finally, opportunity, which we kind of used for a proxy of whether or not the work is already within the purview of another state entity, or if it's something that the new Office of Affordable Healthcare is kind of uniquely positioned to work on. I won't go through this whole table, but this was kind of the summary outcome of our discussions about this, where we assessed each using green for kind of good alignment, orange for on the fence, and then red for where we sort of saw a little bit of conflict with those, that framework for assessment. In particular, I'll just call out prescription drug affordability. I think that was one area where we definitely see prescription drug costs as a big driver and as a challenge in affordability for consumers. But it's also a very difficult area for states to effectively pass and mainly enforce legislation. So trying to think a little bit about that feasibility component, I think in particular, that was part of the reason that it was not one of the 3 domains that we identified and decided to focus on in 2025. Instead, those 3 are regulating prices, aligning incentives for efficiency, and provider market oversight. So I will jump in to a little bit of an update, or I guess I can do a little bit more detail, on those areas of focus. When we were first developing them, we created problem statements for each of the domains that we worked on. The first is the private market oversight and competition, really focused initially on private equity investment and kind of just the changing landscape of healthcare in recent years, where there's been more and more acquisition from private equity and other kind of financial actors in the system that has questionable impacts on both access and quality of care as well as cost. And we saw this as a place where there was opportunity to kind of take proactive protective measures before we start to see problems potentially like have occurred in other states, Massachusetts being a recent example where they had a really difficult situation arise with the closure of a large number of hospitals resulting from financial decisions by a private equity firm. So that was the initial problem we were thinking about with provider market oversight and competition. In terms of regulating commercial prices for health services, we noted, as we shared in the presentation here, that increasing commercial prices for health services are a driver of higher health insurance premiums and out-of-pocket costs. And that's by far kind of the first thing that we hear about as challenges for our consumers. And meanwhile, we hear providers cite difficulty in financing key services, especially primary care and behavioral health care, and also recruiting and retaining staff and clinical staff in particular. So trying to think about, are there opportunities to kind of rebalance, to potentially constrain some prices in ways that could benefit consumers, but also think about, are there places where we feel like payments need to be higher for some services to ensure adequate access? And then finally, aligning incentives to promote efficiency and quality, builds out of that sort of regulation piece to say the whole system of kind of a fee-for-service based payment for healthcare services has some pretty big flaws. And I think there's agreement on that across a lot of actors in the system. And so we wanted to hold some space for thinking about more transformative initiatives to change the way that services are provided, to again get at that issue of it is difficult sometimes when services are declining in utilization. Maybe the price needs to go up to sustain them, but are there ways that we could sort of work together to pay more for quality as opposed to paying for the volume of services provided? So those are the 3 areas we've been working on. Now that I've gone through them, I'll provide an update. So the first is that market oversight component. So on that front, we worked with Representative Zager in the legislature on a bill that he introduced, LD 1972, which would have done a few things. It made changes to the Certificate of Need program to provide sort of a more comprehensive consumer-oriented review of healthcare transactions. and apply those changes to a wider range of transactions in the current Certificate of Need program, which is really focused on essentially like large facility transactions. So would have looked at closure of services, outsourcing of major functions, as well as the acquisition of smaller healthcare entities. The bill was voted down in HCIFS, but it was sort of some of the components and considerations of it were rolled into a legislative commission that was authorized to evaluate the scope of regulatory review and oversight over healthcare transactions. I won't read the rest. So that commission is about to start meeting. I'll be representing the Office of Affordable Healthcare on that commission aside lots of other stakeholders interested in this. The group's tasked with evaluating potential changes to Certificate of Need laws, changes to require regulatory review and oversight of substantial healthcare transactions, as well as the role of private equity companies and real estate investment trusts and their role in sort of risks when they take control of hospitals or other healthcare entities. So just noted the first meeting there, but you can also find a whole page with all the meeting schedule on a page that the legislature maintains. Then on cost containment policies, a focus kind of this idea of regulation of provider prices for commercial payers. We talked about this with the advisory council at our last meeting and are exploring just what other states have done in this area. There's been quite a bit of action in this realm in other states that kind of falls into mostly three big categories. The first is cost growth target programs, which set a benchmark for how much the cost of care should grow annually and has varying mechanisms for holding actors across the delivery system to that benchmark. So includes providers, but often also health insurance companies and sometimes others, and varying degrees and sort of strength of enforcement there. There are some states that do that more as a transparency effort and others that actually, have consequences they can apply for failure to meet the targets. Reference-based pricing in state employee programs. There's a couple states that have instituted Medicare referenced price caps and in some cases price floors for what their state employee health plan spends to kind of handle some of this variation in prices and constrained costs for their health plans. And finally, price caps in public option plans. So I can go on. We have a few state examples here. I won't go through all of them because I know we're already running a little long and I want to get to public comment. I think I described the first two well. In terms of price caps in public option plans, that can look really different in different states. In Colorado, the public option plan has a required premium reduction target for insurance companies offering the public option plan. And if they're not able to achieve that, the Department of Insurance is sort of authorized to come in and set caps for certain providers to help them achieve that. Washington has a very different model where within the public option plan, they just created statutory caps and floors for certain types of healthcare providers. So then I think just to wrap up, I'll go back before we turn to public comment and say, we're still working on the scope of that aligning incentives for efficiency and quality. I think the landscape has changed a little bit with changes at the federal level, both in terms of maybe different expectations around collaboration with the federal government, but also the opportunity that I think is presented in the Rural Health Transformation Program, which is a new program that was authorized alongside changes to Medicaid reimbursement in HR 1, the big bill on funding that Congress passed, but that creates essentially grants to states to work on transformation of rural health and addressing some of these underlying challenges in terms of access and quality and cost. So we're looking to work on that. We probably see that scope of work being more collaborative with stakeholders, with other state agencies, as opposed to legislative at this point, but we are continuing to work on that. So that's just an update. So then I think I'll pause. We'll take a breath. Thank you for bearing with us. It was, I know, a little bit of a long presentation, but I think we've accomplished a lot this year and wanted to share it and highlight that. So now I think we'll stop and hand it over and begin listening to public comment. So Keely's gonna call out folks' names and she'll do who's up next and then the person following, so you'll have a little bit of an idea. Just as a reminder, again, written comments accepted through Friday, October 10th. So feel free to send those in if you want to add anything from today or if folks are attending and would like to submit welcome that. And there's a little link on the slide here to that page. But again, if you go to our work and public hearing, all the information about how to submit those written comments is right there. I'll hand it off to you, Kelly.
Great, so we have, again, I'll go through the first three. We're gonna go through our virtual friends first. I think there are 5 total, and then we'll head to people in the room so we can reorient. So first, we have Kelly Martin and Courtney Shank and Patty Kidder. So Kelly, if you are online and able to come off mute, you can go ahead. He's gone. We'll go to Courtney next, if you're there, Courtney, and you're ready to present.
Hello, can everyone hear me?
Yes, we can. Thank you.
Awesome. So, hello, my name is Courtney Shank, and I moved to Maine in the fall of 2023. I grew up in a very rural town in West Virginia with a population of just around 400 people. And like many families in small towns like mine, we struggled to afford basic necessities, and health insurance was often out of reach. When I was 15, I got my first part-time job as a dishwasher, making $8.50 an hour, which was the minimum wage in West Virginia, and it still is. At the same time, I was a full-time high school student without stable health coverage. My parents couldn't afford to add me to their employer-based plan, so I relied on whatever limited coverage that my high school offered, and even that wasn't always available. On top of physical health issues I faced as a student athlete, such as sprains, dislocations, and other injuries, I also struggled with my mental health. I was diagnosed with depression in high school and needed both therapy sessions and medication to manage it, but getting that care wasn't easy. Without insurance, therapy felt like a luxury, and buying antidepressants was an added expense that my family couldn't always cover. There were times that I had to go without treatment I needed because we just couldn't afford it. And I still remember my parents telling me to try not to get hurt, but not because it would hurt me physically, but emotionally too. And in both cases, getting help came at a cost that we couldn't afford. There were moments I felt like I had to choose between my health and my future. But my senior year, everything changed when I qualified for West Virginia Medicaid, and it was very life-changing. For the first time, I could go to therapy consistently, afford my medications, and see a doctor when I needed to, without worrying about how we would pay for it. I was able to live more fully, both physically and mentally. It's not just about avoiding bills, it was about having a peace of mind and the support I needed to function and succeed. But that peace did not last long. When I moved to Maine for college in 2023, I lost that Medicaid coverage. Medicaid does not cross the state lines, so I was once again uninsured, despite being a full-time college student who is also recognized as homeless on my FAFSA. I worked a part-time job, but like most part-time jobs, those don't come with benefits. My college offers a health insurance plan, but it costs over $5,000 a year, and I cannot afford that. So once again, I found myself in the same position I was in years ago. I'm doing everything I could to stay afloat while living with the constant anxiety that one illness, injury, or mental health crisis could derail everything I've worked for. And that left me asking, why is it so expensive to be healthy? Growing up, we're told, eat healthy, exercise, get 8 hours of sleep, take your vitamins, stay active, take care of your mental health. But how are we supposed to do all of that when basic health care is out of reach? When even a therapist or prescription is considered a luxury? Health insurance should not be a privilege. Being healthy, physically, mentally, and emotionally should not be a luxury. And yet for millions of people like myself, it feels like it is. Just this past summer, I was finally accepted for MaineCare. After 2 full years of being uninsured, I now have access to healthcare again. But getting there was not easy. The application process was complicated and stressful. I had to prove that I was a Maine resident, but as a full-time student, I didn't have a lease in my name or utility bills. I was juggling classes, working part-time, and trying to figure out how to claim my college address as my home. It took a lot of time and energy and a lot of paperwork, And that's even if you know where to start. But thankfully, somehow everything worked out. But the process left me feeling how so many people feel when trying to access the care they're eligible for, overwhelmed, lost, and alone. And now that I finally have coverage, I live with a new kind of fear that it can be taken away. I know how fragile this system is, and I'm scared the current administration will cut federal support that makes this coverage possible. And if that happens, I'll be right back where I started, uninsured, without access to therapy, medications, or even basic care. And the truth is, living in that kind of fear is a health issue. The stress, the anxiety, the dread, it takes a toll. And it leads to even more problems down the line. It's not a secret that healthy people live longer, more stable, and better lives. I want that life, and I deserve that chance, and so does everyone else. My story isn't unique. It's the story of thousands of students, low-income workers, and young people trying to do everything right in a system that is not designed to support them. I've lived with healthcare coverage and without it, and I can tell you from experience, having insurance isn't just about seeing a doctor. It's about dignity. It's about mental stability. It's about being able to live your life without fear. And as we talk about the future of healthcare in this country, I urge lawmakers and other influencers to think about people like myself, people that fall through the cracks even when they're trying to move forward. We need a system that doesn't stop at state borders. We need healthcare that's affordable, accessible, equitable, no matter your income, your zip code, or your age. Thank you, and that's all I have.
Thank you very much, Courtney. Glad to have you here in Maine and glad you've been able to resolve your challenges with MaineCare Access for now. Glad to hear that you are enrolled, but appreciate you sharing your experiences and your story.
Our next three online are Patty Kidder, then we have Linda Sanborn, and then Trevor. So Patty, if you can hear us and come off mute, you are all set to go.
Thank you. My name is Patty Kidder, and I live in the village of Springvale. It's located within the city of Sanford. And I'm here to ask you to do whatever you can to continue to support the financial assistance required to keep insurance premiums affordable in Maine through the ACA. My husband and I are fortunate that we are over 65 years old and therefore have Medicare, and we qualify for Quimby, which helps cover our insurance premiums, deductibles, and copays. But I know if that Quimby goes away, that we cannot afford healthcare without both programs. And that's the same for most seniors in Maine. We still have times when we can't afford my prescriptions and have had to cancel doctor's appointments or tests because we didn't have the money for the copays. Our best and most affordable health care occurred while we had MaineCare, before I started to receive my Social Security benefits and qualified for Medicare. My cousin has had to retire early to take care of her disabled husband. There we go. And she too is too young to qualify for Medicare. Her husband has Medicare and a good supplemental coverage, but she's relying on the ACA marketplace to buy her health insurance. Right now, she's paying almost $500 a month, and she is concerned that if the federal government shuts down, premium will increase to around $1,200 a month. They can't afford that, and she'll have to go without health insurance and without medical care. I know her health will suffer and her husband's conditions will worsen. Who will take care of her husband when she is too sick because of the lack of health care? We need to do whatever we can to help people afford their health care. The ACA makes health insurance affordable and it saves lives. I'm asking you to please do whatever you can to reduce the cost of insurance through the marketplace and increase the coverage that it provides. Everyone needs affordable health care. I thank you all for your time, and I'll do my best to answer any questions.
Thank you very much, Patty. Appreciate you taking the time to be here and to share that. I'll just, briefly say, I know our colleagues at the Office of the Health Insurance Marketplace have done a lot of work to share what some of the impacts of federal reductions in funding would be in terms of the marketplace side. And there's a lot of activity from the administration and others to work in hopes of influencing Congress on that front. So appreciate you sharing that and just wanted to note some of those efforts at the state level.
Thank you so much.
Thank you again.
It looks like we might have Kelly Martin back online if you want to come off mute and provide your testimony. We'll go to Linda Sanborn and then Trevor Putnocki virtually next. Linda, if you're on.
Yeah, good afternoon. Thank you for the opportunity to speak today. I am Linda Sanborn, a retired family physician who practiced in Gorham, Maine for 25 years. In addition to my work in clinical care, I have served as both a state representative and senator, spending a decade learning about and shaping health policy. My commitment to improving healthcare extends to my service on the Board of Consumers for Affordable Healthcare and as a member of the new Primary Care Advisory Coalition. Primary care has always been my passion. Unfortunately, it faces significant challenges in both Maine and across the nation. Despite clear evidence that investing in primary care reduces overall healthcare costs and leads to better health outcomes, primary care continues to struggle. I appreciate the work of the Office of Affordable Healthcare to shine a light on and analyze healthcare costs in the state and to help find solutions to reduce costs. High and rapidly rising healthcare costs harm families, employers, and state budgets. Mainers need solutions now more than ever. Healthcare costs have already been a huge burden for patients, and rising premiums in the state will only make their lives and ability to get more care more difficult. With increasing medical debt and poor population health outcomes, a comprehensive approach with all payer, all provider participation is essential to pushing back against healthcare industry efforts to extract more revenue from Mainers. As the federal government continues not just to ignore the issue, but actively make it worse by taking away Medicaid from families who rely on it, undermining public health protections that keep people healthy, and ending subsidies for the healthcare marketplaces, we need action at the state level. Although comprehensive changes to the system are needed, addressing hospital prices would be a solid first step. Hospitals represent the largest single component of U.S. healthcare spending at greater than 30%, or as we just heard on the statistic for Maine being close to 40%. A large share of healthcare spending is due to affordable hospital care. For example, low back surgeries and associated physician services, high administration costs, and the excessive prices that many hospitals can charge due to monopoly power. Paying hospitals fee-for-service exacerbates runaway spending growth and inequitable access to care. Most hospitals in our state have merged, leaving only a few hospital systems. Thankfully, Maine has put a temporary hold on buyouts by private equity firms who take more profit and provide less quality care. Less competition means higher prices for patients, and as we all know, when patients can't afford care, they're often forced to skip it. Their healthcare conditions become worse, more painful, and more difficult and expensive to treat. Physicians like me appreciate your dedication to this issue on behalf of our patients and all Maine residents. Because powerful interests will oppose this work, those who care about the future of healthcare will need to organize and lead the change. Maine has an opportunity to think systematically and act thoughtfully to build a system to slow spending growth while improving healthcare. Thank you for taking on the challenge.
Thank you very much, Linda. Appreciate those comments and you being here today.
Thank you.
We're gonna go over to Trevor and then Kelly Martin after Trevor, if she's still online. So over to you, Trevor.
Good afternoon, everyone. My name is Trevor Putnaki. I'm the president and CEO of the Healthcare Purchaser Alliance of Maine. I also serve as the chair of the Advisory Council on Affordable Healthcare, but my testimony today is solely in my capacity as CEO of the Purchaser Alliance. The Purchaser Alliance is a nonprofit that represents purchasers of healthcare in Maine. Our mission is to advance healthcare value and to support and incentivize high-quality, affordable care. We have over 70 members, including some of the largest public and private employers and health trusts in Maine. Collectively, our members spend over $1 billion annually providing health care for nearly a quarter of the commercially insured population in the state. Businesses and families in Maine continue to face unsustainable increases in healthcare costs that are leaving Mainers increasingly unable to afford care and employers searching for ways to absorb double-digit premium increases. These rising costs have eaten into wage increases and led to higher premiums, more cost sharing, and higher deductibles for Maine families. In fact, Maine currently has the fourth highest family deductibles in the country and the sixth highest individual deductibles. Small employers, who make up the vast majority of businesses in Maine, have been particularly hard hit, as have their employees. A national survey taken last year found that over half of small businesses have responded to rising healthcare costs by increasing employee contributions to health plans, and nearly half have moved to plans with more limited coverage. Almost 3 in 10 small businesses have cut other employee benefits, and 24% have stopped offering health insurance altogether. And based on preliminary information from the Bureau of Insurance, small employers' 2026 premiums are going to increase even more than usual. The cost of small group plan coverage is projected to increase by an average of 17.5% for next year. And as we just heard, one of the main factors driving healthcare cost increases is the rising cost of hospital care, with hospital spend comprising over 50% of our members' combined medical and pharmacy claims. Yet at the same time, hospital prices continue to rise. We've all heard from our hospitals, and we can see in their financial statements that many of them are operating with narrow or negative margins. Hospitals have primarily addressed these financial challenges by increasing prices in the commercial market. And because the highly consolidated nature of our delivery system gives them outside leverage in contract negotiations, hospitals have been largely successful in securing rate increases from the commercial market. This is consistent with national studies, which have found that prices in consolidated markets are higher than in competitive markets, with one study estimating average prices are 12% higher in monopoly hospitals compared to markets with robust competition. Results from that same study suggest that bargaining leverage is an important component in price variation. While the HPA has a great deal of empathy for the financial difficulties facing our hospitals, they're not the only ones facing financial challenges. With the cost of healthcare continuing to rise, Maine consumers are increasingly struggling to cover the cost of healthcare. A survey of Mainers from last year, as was noted, revealed the extent of those struggles, with more than 1 in 3 Mainers reporting that they skipped or delayed going to the doctor when they were sick due to costs, and 1/3 struggled to pay for basic necessities like food, heat, or housing due to medical bills. We believe that stakeholders must work together to support strategies that encourage hospitals to prioritize efficiency. While we know that many hospitals are taking action to curb costs, we believe there must be more focus in this area rather than continued reliance on price increases to address shortfalls. Improving hospital efficiency work is hard, but it is not impossible. There are examples throughout the country that have succeeded in improving efficiency, strategies we believe could work in Maine. By making efficiency a priority, University Hospital System in Ohio reduced the cost of treating Medicare enrollees by 1/3 over just the course of a year and a half, ultimately getting to profitability on Medicare reimbursement. Undertaking similar initiatives in Maine could improve hospitals' financial status without further increasing the cost of care for Maine families and employers. Undertaking this work will be difficult, much more difficult for hospitals than raising prices would be, but Mainers can no longer afford to absorb continued rate increases from hospitals that far exceed inflation. Paying more every year is simply not an acceptable solution. We must work together to encourage and support meaningful, transparent, and measurable improvements in affordability. The alternative is no longer sustainable. Thank you very much for the opportunity to deliver these remarks.
Thank you, Trevor. Appreciate you taking the time to be here.
Next up, and this is our last virtual attendee, we have Kelly, and then we'll come into the room and we have Ann Sedlak first. So Kelly, if you're online still, feel free to hop off mute.
I am. Can you hear me?
Go ahead.
Yep.
Great. Sorry for all the technical difficulties. I
problem.
would like to share my healthcare cost experience with the Office of Healthcare Affordability. My name is Kelly Martin. I'm a social worker from Cumberland County. I have experienced 3 major barriers in affordable healthcare coverage: expensive or inadequate employer coverage, coverage denials, and high premiums on the marketplace for a household of 1. A few years ago, I landed what I thought was my dream job, working at a long-term care facility. I signed up for the employer coverage made available to me, confirmed with my provider that my upcoming care would be covered, and settled into my new job. I'm a cancer survivor, and the care I spoke with my provider about being covered was follow-up treatment from a screening. I was shocked to learn that despite my research and being told my care would be covered, it wasn't. I learned that my employer had what was called a self-funded plan and wasn't required to cover the 10 essential benefits other plans have to cover. With the help of the Consumer Assistance Program, a lot of time and energy, I was able to make a complaint to the Department of Labor, and my employer did cover my care. If I had not had the help of Consumers for Affordable Health Care, I would be making payments on a $10,000 bill. I knew that my employer's plan was not going to cover the medical care I needed, so I began shopping at covermemaine.gov for a marketplace plan. I am a professional. I live on my own. I am in my 50s, and I was shocked to see that even with subsidies, I would be paying over $400 a month for premiums and have a $7,000 deductible. Times are hard. Housing, utilities, food, transportation. So the premiums just were not feasible. So I decided to go without coverage. It has been almost 2 years now since I've had medical health insurance. So fast forward to a few weeks ago, I am suddenly out of a job. I am grateful for unemployment, but it's not enough to get to pay for premiums for health care. I am over income for MaineCare, and I don't believe the marketplace is affordable for someone in my situation. I'm looking for a new job, hopefully one that will have affordable and comprehensive coverage. If not, I will find myself back in the marketplace. It's based on everything I've heard so far today. It's a really scary situation. I urge the Office of Health Insurance Affordability to do what it can to address these concerns that many of us Mainers are facing, that healthcare insurance is just not affordable for folks like me, for many folks. And I appreciate your time.
Thank you, Kelly, for sharing that. I'm very sorry for the challenges that you've been facing, and no, it's not easy to share about that. So thank you for being willing to share that with us. Really appreciate it.
We have Anne first, and then we'll go to Jane Pringle and then Kate Envy.
Good afternoon. My name is Ann Sedlak. I'm the Director of Advocacy at the Maine Medical Association. Maine Medical Association is a professional organization representing more than 4,300 physicians, residents, and medical students in Maine. We wanted to come today to just express our appreciation to the Office of Affordable Healthcare for providing annual opportunities to provide formal feedback and for its commitment to ongoing collaboration between these hearings. As noted in our previous testimonies, our association is actively involved in seeking to engage our members and the healthcare practitioner community in the public discussion and debate of the future of our healthcare system. Our ad hoc steering committee on healthcare system reform launched the statement on reform of the healthcare system in 2023. As noted at the beginning of the statement, we believe that our current healthcare system produces some of the world's most eminent clinicians and healthcare facilities, which together provide some of the most advanced medical care in the world. But despite sustained efforts by physicians and other healthcare workers, our system fails both patients and physicians in multiple ways. Actions should be taken immediately to create a system that provides access to healthcare for all as a public good, contains costs, eliminates healthcare disparities, and ensures a robust public health system. Follow-up efforts this year on behalf of that ad hoc steering committee include engaging members in a video series where Maine physicians, residents, and medical students provide commentary on the state of the healthcare system. We've now done more QR codes. We heard people like it, so you can actually see on the written testimony the link for those video statements. Additionally, the ad hoc steering committee recommended establishing a permanent forum within the MMA for our members to gather for discussion, education, and advocacy on healthcare reform. As such, our board of directors voted at our annual meeting this September to amend our bylaws and create the section on the future of U.S. healthcare committee. The purpose of this committee is a few things, and it includes providing a forum for discussion, debate, learning, and advocacy, and exploring the physician's role in the health systems of peer countries that have functional systems worthy of comparison, and promoting the clinician voice in the public debate about the future of the healthcare system. We hope that this section will be a resource to the office as it continues its important work, and we thank you for considering the thoughts of Maine physicians.
Pringle, then Kate Undy, and then Dan DeMeritt.
Thank you very much, Ms. Garrett Reed and members of your advisory council, and for your whole office and for your outstanding work. I'm Jane Pringle and I live in Windham, and I'm actually here to share my experience as a consumer of healthcare. But I would ask that as you listen to my problems, think about how a single payer system that pays the same price for all patients, for all drugs, for all services, the simplicity of that, how that would solve the problems that my husband and I have experienced. I'm going to share my frustrations with the systems that we use to obtain our health care. We're retired physicians, and we're lucky to have some understanding of how to advocate and navigate for the care we need. We also understand that some of the rising costs relate to the amazing advances in medical science and technology that allows us to continue to live longer and more functional lives as we age. And that's true for my husband and myself for sure. There are three areas that are costing us personally: time, money, and aggravation. They are rising premiums, arguing about coverage, and asking for the best price. The first area is steadily rising premiums for our Medicare supplement plans. We have been able to have coverage through our employer-based insurance until we were ages 67 and 74, when we began taking Medicare A and using Harvard Pilgrim Healthcare for our Medicare B, using a healthcare reimbursement account of $2,200 for retirees from my employer. Medicare required me to provide proof of credible continuous coverage to qualify for the lowest Medicare A and B premiums without penalty. Just think, a single payer system always pays you no matter whether you're working or who your employer was. Wouldn't have to do, I can tell you, I looked through paperwork yesterday and I had forgotten all the hassle that I'd had of getting data approved to send into Medicare, so I didn't have to pay the, what is it called, the IRMA? Anyway, they're very complex systems, which make our Medicare system not very simple. Then between 2015 and January 2024, our Medicare Supplement Plan F, again, we bought the best coverage. We knew that we didn't want deductibles. We wanted to be able to travel abroad. Why does Medicare have 6 different plans? There ought to be one plan for all of us. It covers all of our healthcare needs. But we took the best plan. We had it with Harvard Pilgrim Healthcare, and it rose from 186 per person to 319 per person as of last year. At that point, we were able to obtain our supplemental insurance through USAA. My husband served in the Navy, and we had a benefit. That plan at that point was $224.40 per month per person. Because the plan wasn't included in my employer options, we lost our $2,200 per year healthcare reimbursement account. But it was still cheaper to go with the USAA plan. Wouldn't it be wonderful if we had a single plan, paid the same thing, cost the same to everybody? But even with that cost, our insurance was lower. The second area is arguing about coverage. In November 2024, my husband underwent major surgery. He required 7 days of hospitalization, 7 days of inpatient rehab at a rehab hospital about a mile away. Knowing how expensive ambulance transport is, I asked if I could transport him in my car. But the hospitalist knew that his blood pressure was very labile and he was lightheaded when he would get upright. He also was having bowel problems. He'd had an ileal loop and conduit urinary diversion, so his GI tract was going up and down between constipation and diarrhea. He was having bowel problems related to a surgery. It became clear ambulance transport was the safest route. I looked in my Medicare book, and anyone with Medicare, no matter which plan, if it's medically necessary, it's that ambulance transport's covered. But we have non-medical people having to code because Medicare wants proof that the service was provided. So unfortunately, we kept getting billed for the ambulance transport because the hospitalists and the surgeons worked together. The surgeon was the doctor of record. He didn't order the ambulance transport as medically necessary. The hospitalist did. He knew that it was. But it took me not just phone calls, and believe me, I love my hospital, but I can speak to someone. And when I said, I offered to make the transport, they assumed that if I offered to make the transport, then it wasn't medically necessary. So I finally had to write a long appeal, and I finally had to call the urologist's office, who then called the hospital to make sure that the coding that was necessary to show that the doctor of record felt this was medically necessary. So fortunately, but my time is worth some money, I think. So I spent a fair amount of money to save us that $2,000 or $3,000 bill. Then the third area of frustration is when I go to the pharmacy for several expensive medications. I need to ask the pharmacist for the best price. Now, I like to shop around. I might go to this store and this store and this store. I'm a bargain hunter. And I think that's reasonable for things like clothing or a TV. For my health care, for a medicine that I need, but we have a Medicare D plan with WellCare. It's actually the Medicare Compare enables you to plug in your meds and your pharmacy. You have to have an approved pharmacy, but you can figure out what the best plan is. But there are multiple tiers, and in fact, we're adding a new tier this year. But it turns out that in the same pharmacy for the same drug, there are 3 different prices at least. If you use GoodRx or Hannaford's plan or my WellCare D plan. So I happen to have a few new therapies for my skin cancers that are fairly expensive. And so the pharmacy, when they see more than $100 copay, and I see this every time I wait in line or you hear somebody else being canceled, did you expect that your copay would be this amount? And sometimes I answer, yeah, I did. my 5-FU cancer therapy that I put on my skin cost that much, 10 years ago. And it lasted me 10 years. So yeah, I can handle $100 over that. But when I had to have an immunotherapy tacrolimus ointment for my eczema, well, guess what? That's about $400. And so I said, well, wait a minute. I have GoodRx. Well, it turned out in that same pharmacy, there were 3 prices. And the best one was Hannaford RX. And it came down to an amount that I could pay. Is that really a good healthcare system? I saw someone being counseled just this week who had a requirement for diabetes care. The pharmacy tech was doing, in fact, the pharmacist came over to counsel them because they said, we are waiting for a prior auth that hasn't come in yet. Do you have enough med to last? And so there was quite a long conversation, keeping a lot of other people waiting. And that pharmacist had options through Hannaford to be able to provide a bridging prescription so that person wouldn't have bad problem with low blood sugar or hospitalization. So I love watching people around Maine who work hard to advocate, to care for each other. But frankly, I don't get what it is about we Americans. We're so bloody stupid. We won't let go of our desire to have choice. I believe in capitalism, but I'm sorry, healthcare is not the place for it. Every other country, developed world, look at the cost that we put into this. And I love the work you're doing, but the root cause, I watch how many good hospitalists leave patient care to go fight prior authorizations. You talked about money that was supposedly paid, but then you acknowledged we don't know what really got paid. You know how many bills are not paid to the hospital that are just, even though you've got full documentation that you're talking about this urgent care of cardiovascular, cerebrovascular, truly amazing therapies we have today for people who would have died 20 years ago from these various health problems. And yet, we're losing good clinicians to taking care of fighting insurance companies. The for-profit healthcare in this country is what's killing our system. And anything that you can do, and I will do anything I can to support you, to get legislation to outlaw for-profit healthcare and take all that billions of dollars that's going to stockholders. And I have stock that I like to collect my dividends on, but I don't want it to be a healthcare company. I don't want it to be money that keeps Julie from getting the care that she needs, or that the people that I love and care about are not able. And this is why we're in the mess we're in. The big picture is really important here. Anyway, thanks for listening. I brought an example of my Medicare 2025 book. Look how many wonderful choices this is page after page after page. Medicaid, Medicare Advantage. We need to reform Medicare, and we need to reform our core system. Thank you.
Andy, then Dan Demerit, and then Katie Phillip.
Good afternoon, and thank you for the opportunity to present these comments regarding affordability barriers Mainers face in accessing healthcare and coverage. Kate Endy, I'm the Policy Director at Consumers for Affordable Healthcare. Consumers for Affordable Healthcare is a nonprofit, nonpartisan organization working to improve access to quality, affordable, and equitable healthcare for all Mainers. I also serve as the Vice Chair to the Advisory Council on the Office of Affordable Healthcare, but am not here in that capacity. I'm here in my capacity as an employee of Consumers for Affordable Healthcare. We are designated by Maine's Attorney General as Maine's Health Insurance Consumer Assistance Program, or CAP. The CAP program provides a toll-free and in-person access to certified Maine enrollment assisters and trained individuals who help Mainers understand their health coverage options, apply for and enroll in private health insurance, and appeal inappropriate insurance denials. It's from that perspective that we offer these comments today. And we will be submitting more detailed written comments, including detailing some barriers to affordability and accessing care, such as high deductibles, out-of-pocket costs, and difficulties navigating private insurance utilization management and appeals processes. However, today I will focus on a few of the larger trends impacting affordability. And I wanted to start by sharing just a few stories we've heard from Colorado Star Helpline this year. We heard from a former federal employee from Cumberland County who lost his job due to the federal cutbacks. He and his wife were over income for Maine Care, and his family of four was looking at plans that cost $1,100 a month, a price tag that, based on his lack of income at the time and unknown employment prospects, was far too expensive. The caller from Kennebec County, who, even with employer coverage, is struggling to pay down a $9,000 hospital bill since she does not qualify for financial assistance under the current hospital free care guidelines. A self-employed caller from Cumberland County with a family of three. If the enhanced subsidies are not extended next year, their household will no longer be eligible for any premium subsidies through the marketplace. This, combined with the steep rate increases in high deductibles and the unpredictability of self-employment income, has caused significant concern about their ability to afford coverage for their family next year. A caller from York County, who is 1 year away from being eligible for Medicare. He can no longer afford his marketplace plan, is considering dropping it, even though he has health issues that require medications. A caller from Hancock County, who has employer coverage that does not cover his diabetes medications, Jardiance and Januvia. He cannot afford to pay $1,700 out of pocket, so he has gone without his diabetic medications. These are just a few of the stories we have heard from Mainers who are struggling to afford health insurance coverage, hospital bills, and prescription drugs. Polling conducted in Maine has found that these affordability barriers are widespread. Almost half of Maine households have incurred medical debt within the past 2 years. The large majority, 2 out of 3 of those, were covered by insurance when they took on that debt. 2 out of 3 families have experienced financial impacts such as a result of medical bills, mostly struggling for to pay for basic necessities like food, housing, or heat, or being sent to collection agencies. Half of Mainers with commercial insurance are concerned they will lose their coverage because they cannot afford it. And more than 80% of respondents who were uninsured cited expensive premiums as a barrier to obtaining health insurance. The results from polling were conducted in Maine from December 2024 through January 2025, during which the enhanced premium tax credits were still lowering premium costs for more than 50,000 Mainers. These survey results also do not take into account the significant rate hikes that will go into effect in January 2026. Premium rates for individual plans in Maine will go up, as we've heard, by an average of 24%, and small group plans will have an average premium increase of 18%, which together will impact 115,000 Mainers and small businesses who struggle to provide coverage for their employees. These premium rate increases will further exacerbate healthcare affordability barriers faced by families and small businesses, especially when implemented in conjunction with the expiration of enhanced premium tax credits and increases to deductibles, out-of-pocket maximums, and other cost-sharing amounts. These rate hikes are simply not sustainable. Maine people and employers cannot afford double-digit increases to already unaffordable health insurance premiums. While we are concerned with increases in insurance company profits, public rate filing documents show that increases in medical and prescription drug costs are the largest cost drivers. For that reason, we believe it's imperative that policymakers take steps to address underlying healthcare and prescription drug costs. First and foremost, I want to emphasize the importance that we prevent further market deterioration, as was explained earlier. With the expiration of the enhanced premium tax credits, we are expecting some people to drop coverage altogether, most likely people who are healthier and can afford to do so. There is a pending bill in the legislature that would permit unregulated, non-ACA compliant plans to be sold in Maine, Farm Bureau plans for short. We have serious concerns that if those plans are introduced, that they will not only put consumers who enroll in them at risk, but will also pull younger, healthier people out of Maine's merged market risk pool and will cause further premium increases for individuals and small businesses. Now to some of the cost drivers that were mentioned. Hospital care makes up the largest percentage of healthcare expenditures in Maine compared to other service categories, and most Mainers with medical debt attribute it to a hospital service. 1 out of 3 Mainers report that they have struggled to pay for basic necessities like food, heat, or housing due to a hospital bill. And more than half of Mainers with hospital-related medical debt are not aware. That means nonprofit hospitals are required to provide free medically necessary care. Especially at a time with healthcare costs rising quickly, it's more important than ever that Mainers are aware of and can easily access financial assistance programs. We continue to hear from people through our helpline who have been struggling to pay for hospital bills, only to find out free care was available, or have had difficulty affording payment plans. During the last legislative session, the legislature and Governor Mills signed a bill into law, which will strengthen Maine's hospital free care law. And once implemented, we hope will address many of these issues. However, even with this new law, many Mainers will not be eligible for financial assistance or payment plans, which, along with the fact that high hospital costs are also contributing to unaffordable premiums, we strongly believe that policies are needed to address rising costs. Several states have captured savings by utilizing Medicare reference-based pricing for services, and we suggest the office consider similar policies to create savings for Maine people and employers. Too often, we hear from Mainers through our helpline who are struggling to afford the cost of prescription drugs they need, some of whom are forced to make difficult choices between paying for medicine or being able to provide for their families and put food on the table. 1 in 3 Mainers report they have postponed filling or refilling prescriptions, split pills in half, skipped doses of medicine, or did not fill a prescription due to costs. And as has been noted before, rising prescription drug costs are another significant driver of premium increases. The Inflation Reduction Act, passed in 2022, contains several provisions requiring HHS to negotiate prices for some of the costliest prescription drugs covered by Medicare. And I'll just note that Maryland and Colorado's prescription drug affordability boards have been moving forward with establishing upper payment limits for certain high-cost drugs. We believe Maine's prescription drug affordability board and policymakers should consider similar policies that would constrain the rising cost of prescription drugs, such as by requiring public payers to create savings by utilizing maximum payer prices for drugs negotiated by Medicare. And finally, I just want to note that we've talked a lot about rising costs and barriers to coverage, but there are some people living in Maine residents that don't have access to any coverage at all, and then need to address closing coverage gaps, specifically for immigrants in Maine. Governor Mills and the Maine legislature previously took a significant step in improving healthcare affordability and advancing healthcare equity by restoring eligibility for Maine care to children and pregnant people, regardless of their immigration status. However, the coverage gap that still exists for adults and many immigrants living and working in Maine who are ineligible for Maine care due to their status. Removing this discriminatory exclusion so that all income eligible people that live in Maine can have access to coverage for the same scope of services through Maine care, regardless of their immigration status, is crucial to addressing healthcare affordability. Thank you very much for this opportunity, and we will, as I mentioned, be submitting writing comments.
Dan Demerit, then Katie Fulham Harris, and last but not least, we have Julie.
Thank you. I'm looking around for a timer. I'm not seeing one. So for all of you, I'm internally trained to speak for 3 minutes at a time and no longer. If you want to see me talk a lot longer, you can tune into the Orno Town Council meeting tonight at 5 o'clock and watch me go. My name is Dan Demerit. I'm the Executive Director of the Maine Association of Health Plans. Our association includes 5 health plans in Maine, providing or administrating health insurance coverage to more than 600,000 Mainers. The 2026 coverage year, we already heard about quite a bit about today. It's going to present some unique challenges for Maine's healthcare system, its insurance carriers, and most concerning of all, its consumers. Maine is facing significant increases in health insurance premiums, and we've heard reported the averages are expected to be 24% in the individual market and 17.5% in the small group market, impacting over 100,000 Mainers. These premiums, as we speak at events like this or at the legislature, continue to be a direct reflection of the underlying costs of healthcare. The rates proposed by Maine's carriers must and do reflect this. And the real impact, of these higher rates was shared in a really challenging way in some instances by the 130 Mainers who signed up for and in some cases waited hours to participate in the Bureau of Insurance Health Insurance Rate Public Forum in the middle of August. A lot of hard stories about the impacts of higher premiums and access to care. So we appreciate, as an association, our member plans, this opportunity to come together and the work that the office does and the team does to bring transparency to what's driving costs in our healthcare system and bring people together. I think we're all of good intent in this space and to promote discussions around achievable reform. So thank you for that. What's driving the rates this year is the unsustainable trends to healthcare costs in part that are long been a part of our higher healthcare costs in the state. I would like to bring with me that slide number 9 from earlier today, the Wakely report, wherever I go. It talks about the per unit costs and the only component that contributed to lower premiums in the 2025 year when there was a 9.1% average increase was the work that carriers did in plan design. So that was the only negative contributor across all the other factors. And that's something that I think is telling. Of course, but what's really driving rates this year is the uncertainty of market disruptions coming from factors that are beyond our control necessarily. Maine, as much as we will advocate for changes in federal action, millions of Americans, thousands of Mainers are expected to lose their federal enhanced advanced premium tax credits for 2026. These enhanced tax credits help make insurance through Maine's health insurance marketplace more affordable. These increased costs will mean many younger and healthier individuals are likely to drop coverage, driving up costs. Medicaid redetermination has also served to increase rates in emerged markets as the population formerly on Medicaid trends to be a higher cost population. A second unknown cost or concern that I don't think we've talked about yet today, or others haven't talked about yet, are federal changes in eligibility coupled with higher premiums and the impact that'll have on catastrophic coverage as these plans may be the right fit for some, offering lower premiums and basic benefits, but will also expose other individuals and families to higher deductibles and out-of-pocket costs when they need care. Over reliance on catastrophic policies by consumers in the need of more robust coverage can create barriers to preventable and ongoing care, contribute to medical debt, financial insecurity, and may have unexpected impacts on the risk pool and costs of providing coverage. We urge policymakers and healthcare stakeholders to monitor this carefully in the coming year. As we look ahead to in addition to the cost trends, the uncertainties, we also have the known costs and compounding costs of policy decisions that include mandated coverage expansions, limited utilization management tools, increased administrative burdens, and restricted plan design options, and insurance market innovations that weigh up over time to drive up the cost of care. An example of this would be the McGarrett expansion of the reinsurance program and the impact. It's gone from having a 17% impact on premiums in 2020 to just 5.4% expected in 2026 as part of that program. We urge stakeholders and the Office of Affordable Healthcare, and we'll have comments in writing as well before the October 10th deadline, but we encourage everyone to support what works. Utilization management, we have disagreements about administrative burdens of that, while acknowledging their administrative burdens, but it's an important strategy that's been rolled back and limited twice in the last 2 years by the legislature, by laws that have been passed. I would share that there's a national initiative announced by the American Health Insurance Plans this summer that highlights how health plans are voluntarily streamlining and modernizing prior authorization. And we look forward to the improvements that'll have the experience across the healthcare system. Wrapping up, we'd urge things that do work are plan design, coverage, and price decisions. We have an incredibly complex, costly healthcare system. Health plans leverage data, research, medical expertise, prior year experience, and actuarial science to build provider networks and develop and price plans that provide consumers with access to affordable, evidence-based care. Concerned about things that restrict the ability of carriers to do that work. We urge us to promote and consider how modernization and interoperability can make an impact on the experience and achieve savings. And we do have concerns about, I'll finish up by saying we do have concerns about and have to consider the monopolistic provider behavior and practices and the impact they're having on our health insurance costs and the cost of health care in general. We have competitive healthcare markets that are more affordable and provide patients with choices across a range of evidence-based care that they need. We're seeing in Maine, we must be on the watch for monopolistic behaviors given the rampant consolidations we've had in Maine, because they're barriers to alternatives, they limit innovation, inflate prices, drive up costs for everyone. With that, I'll end. Again, we will submit written comments for the record, but I appreciate the opportunity to be a part of today's public hearing. So thank you.
Good afternoon, co-chairs Andy and, oh, she's gone. Oh, there she is. Sorry, can't see with my glasses on. Andy Podnaki, members of the council and the team here. I'm Katie Fulham Harris of Maine Health, and I appreciate the opportunity to provide comments today. I think we can all agree that the rising cost of healthcare is creating huge burdens on patients, on employers and plan sponsors, on government, and actually on providers and hospital systems as well. Premiums are rising, out-of-pocket expenses are increasing, and bad debt is escalating. And this situation precedes the $5 billion estimated reductions in federal funds that will result from the most recent budget reconciliation law, as quoted by the Department of Health and Human Services recently, and the possibility, and the real possibility, that the enhanced premium tax credits that support our marketplace will be allowed to expire. At the same time that health insurance premiums and out-of-pocket expenses are increasing, Maine's hospitals are also facing tremendous financial pressures, and it's bordering on a crisis. I included data in the comments that I submitted that show the impact of the crisis, and it's really not a pretty picture. And that's further backed up by data published by the Center for Healthcare Quality and Payment, which recently indicated that 12 Maine hospitals have recently lost services, 11 are at risk of closing, and 5 are at immediate risk of closing. It's pretty dire. We're facing a complex challenge in Maine. How do we address rising healthcare costs in an environment in which our delivery system is precariously unstable? It would be prudent to do so very carefully and to avoid unintended consequences. One suggestion is to adopt the triple aim as a principle in reviewing the possible solutions. The triple aim framework provides equal weight to quality, access, and cost. It's a concept that is critically important to identifying the impact of solutions on all aspects of healthcare and thus avoid situations in which we lower cost at the expense of high quality or access to needed care. A second suggestion is to look at the drivers of rising healthcare costs in Maine from a variety of perspectives before seeking solutions. Demographics, geographic challenges, and the state's economic climate, including its workforce, all play roles in healthcare costs. The inputs that businesses face, all businesses, further contribute to the problem. Popular public policies, and actually McGarrett was just mentioned, such as paid family leave and insurance mandates, add to the cost, as do the state's electricity costs and labor shortages. In spite of these escalating inputs, Maine Health is seeking 4.5% rate increases this year across the board. And it's at a time when our plan sponsor costs, as we've heard today, are increasing at double digits. I want to emphasize that. The provider community, largest provider system in the state, is seeking 4.5% increases from the carriers in our monopolistic way here, from the carriers that are then passing on costs at double-digit rates. We have to look at utilization as well as the prices. And I know some work has gone into that. I appreciate that, but it is critical that we do so. A recent JAMA article noted that the median price for new drugs launched in 2022 was $228,000. In 2011, not very long ago, the median new drug price was $31,000. And when we talk about unit price on the inpatient side, drugs are part of that. So we can't just look, when we talk about hospitals, you need to look at the inputs that go into hospital prices. It's really important to understand the dynamics behind rising costs before identifying solutions. How do the increasing administrative burdens created by insurers add to escalating costs? Maine Health has over 1,200 care team members devoted to billing and payment, the vast majority of whom are responsible for addressing commercial carrier and MA plans, Medicare Advantage plans, prior authorization requirements, and other administrative barriers. And specifically, I just got this data, we have 3.5 times the number of FTEs for commercial and MA plans compared to Medicare, just to get reimbursed. There is a deliberate and heavily subsidized campaign being waged at the national and state levels that identifies hospitals as the cause of escalating healthcare costs. The solution that some have identified is to artificially cap hospital prices or cost growth in general. Doing so absent understanding the drivers of hospital costs, and particularly in Maine, and the implications that such policies will have on quality and access, as well as cost, could result in damage to an already precarious healthcare delivery system. One size does not fit all in health policy. Markets look very different between states and regions in the country. We should not rely upon identified solutions that do not reflect our experience. We are one big small town, and we have an opportunity to do things differently. Our hospitals are nonprofit, our provider communities are committed to improving the health of their patients, and we have a strong source of cost data in the MHDO. We have a history of working better together. So let's use this opportunity to join together to address the growing healthcare cost burden in a thoughtful, comprehensive, and data-driven way. Together, let's not jump to conclusions with the solutions. Let's work together to identify those solutions. Thank you.
Hi, thank you to the Office of Affordable Healthcare for bringing us all together today. And I thought I was going to be here till 5, but we're all going to get out here early unless I read all 12 pages of my written testimony that I'm going to submit, which I'll spare you from. I'm here on behalf of Maine All Care. And as most of you already know, Maine All Care, established in 2010, has been tirelessly advocating for a publicly funded healthcare system for everyone in Maine. The things that we're all struggling with, that we're all facing, are well known. I'm going to skip that part and just talk about why incremental reforms, although they may be necessary in the short and immediate term, they do not solve the problem. If we want to continue to provide high quality care at an affordable cost and an equitable cost, we are going to need a universal healthcare program for Maine. Ideally for the whole country, although given where the country's at right now, I'm not optimistic that that's going to happen anytime soon. When incremental reforms are implemented, insurance companies, pharmacy benefit managers, and large hospital entities will always find a way to work the system to their advantage. Here's some examples. In 2024, Congress passed legislation to limit copays for 10 expensive drugs, including insulin. Dr. Sanborn, who testified earlier, and I participated in a press conference lauding this reform. However, the costs for other drugs have skyrocketed. A personal example, my husband's asthma inhaler copay increased from $40 to over $200. And if their premium increases are limited, insurance companies respond by reducing coverage, increasing copays, deductibles, out-of-pocket maximums, and looking at clawing back payments they've already made to providers. As far as the increasing deductibles and copays, this happened last year with both my health insurance and my long-term care insurance. Hospitals have responded by reducing staffing levels and cutting or closing unprofitable programs. Maine All Care has been keeping a list of closures in 2025. I included that in my testimony. We know of at least 9 hospitals, programs, units, or clinics that have closed or are slated for closure, and I expect the list is much longer than that. And as if that's not bad enough, we are revisiting another moment where the biggest insurer and one of the biggest hospital systems in the state are at loggerheads, with the potential to disrupt healthcare for thousands more Mainers. On behalf of Maine All Care, I pose this question: why do we have health networks at all? To add to Dr. Pringle's question, why do we have 5 different prices at one pharmacy for different medicines? The answer, because these types of barriers and because healthcare networks and narrowing healthcare networks are one way that insurers can limit the amount of money they pay out to maximize their profits. As for-profit corporations, this is what insurance companies are chartered to do. It's not their fault. It's the way the system is set up. And they are set up to maximize benefits or maximize profits for their shareholders. It is a failure of our public policy that permits profit-driven companies to control so much of our healthcare system. The United States is the only developed country in the world to do so. It is time to rethink our priorities and our values. It is time to declare our decades-long experiment with market-driven, for-profit healthcare a failure. This is why we are urging that we fundamentally change our system. Maine All Care has commissioned 2 recent analyses by the Maine Center for Economic Policy to look at the costs on fiscal analysis of universal health care. Based on these studies, we at Maine All Care know that a universal publicly funded healthcare system for Maine remains fiscally feasible. We asked the legislature via LD 1269 to consider an independent study of the cost of universal health care in Maine. This was voted ought not to pass, unfortunately. However, the Health Coverage Insurance and Financial Services Committee did direct your office, the Office of Affordable Health Care, to review prior studies and develop recommendations for potential policy options for the committee's consideration. And we look forward to this report later this fall, we hope. In summary, Maine must refuse to stand by while healthcare costs, program and hospital closures, rising unaffordable healthcare insurance premiums continue to push Mainers off their healthcare and put Maine lives at risk. We believe that it is critical that Maine leaders examine the cost drivers within their control, and that's one of the that's a few of the pages is what work that Maine All Care has done to break down some of these cost drivers and look at ones that are in the state's control versus the federal control. And we must move forward to implement universal health care now, providing comprehensive health care for all Mainers and securing our hospitals with a single payer system. Thank you.
With that, that's the end of the list of folks that we had signed up to testify today. So just wanted to say one more thank you to everyone who took the time to come and join us and to share thoughts. Once again, another pitch. Anyone else who would like to share comments, feel free to submit those in writing before October 10th. And I hope you all have a great rest of your day. I would say we'll see you next year, but I think I'll see most of you before then. So just thank you again.
Do you know when you'll be issuing your slip for committees?